Urogynecology, it's a subspecialty of obstetrics and gynecology, which deals with female pelvic floor disorders, and this involves situations such as urinary incontinence or overactive bladder, problems with voiding, prolapse, which is actually hernias of the vagina, and bowel dysfunction. Let's start with the bladder, for instance. They may have urinary incontinence, frequency, urgency, feel like they have to go to the bathroom all the time, very common, waking up a lot in the middle of the night, recurrent urinary tract infections. Some of the patients have pain when their bladder is full or problems voiding. So that would basically be the bladder symptoms. As far as the support issues, prolapse usually manifests itself as bulge from the vagina. These are basically hernias of the bladder or the rectum or the bowels through the vagina. So they may notice that, may have discomfort or pain. Some patients may manifest pelvic floor dysfunction from problems with constipation or even bowel incontinence. And then you kind of then also go to the spectrum of pain with intercourse. When she has symptoms that are disruptive to her life or her lifestyle is usually when we recommend that she seek referral. It can be from her gynecologist, her primary care doctor, or on her own accord. It usually takes a while because they usually are a little embarrassed about it, and I would say probably a year or so. They're certainly not alone. If you look at lifetime risk of needing surgery for pelvic organ prolapse, it's 1 in 9. Same risk of breast cancer, so it's a very common condition. And urinary incontinence can be as high as 50% depending on the age. And then again, it depends on how it impacts the person. So these are conditions that are fairly common, that women have historically been told, oh, it's just part of aging. You just have to live with it. But you certainly don't. There are many treatments that have been made much easier, much quicker recoveries, much more effective in the recent decade as compared to previous therapies. We do a complete history and physical examination of the patient, and we basically come up with a comprehensive program to not only treat but to diagnose exactly what's going on. And that, I think, which differentiates us from other physicians, is that we treat the entire pelvic floor and not just one area. And once the patient is done with their original visit, then it usually involves doing some testing in the office and then potentially some therapy in the office as well. The nice thing about what we do is that we see the patients and we're able to basically enlighten and educate them in exactly what their diagnoses are, then give them treatment options, and then it's really up to them. And I think that at minimum it's always good to be informed about what's going on and what your options are. And the majority of the time they can have something done, can fix their problem, restore their activity and function, and get them going again. We offer in-office cystourethropy, where we're able to examine the patient's bladder and the urethra in the office. It's not uncomfortable. It takes just a few minutes. Most patients are very surprised that it is not painful. With that, we're able to rule out any anomalies or abnormalities in the bladder and the urethra, which thankfully most of the time it's normal. The second evaluation of the bladder usually entails urodynamic studies, which is basically a test of the bladder function. So we fill the bladder with water. It takes about 45 minutes, and that test tells us how big the bladder is, why they're leaking urine if they are, or if they're having problems voiding, why they're having problems voiding. The therapeutic side, we do in-house pelvic floor rehabilitation, which is a very comprehensive program looking at the pelvic floor. For pelvic organ prolapse, there's, as I said again, there's conservative or surgical options. A conservative option would be a pessary, which are devices that women can put in the vagina to hold up the prolapse and can give them immediate relief from the symptom of prolapse, and they can use it long term. So that is, been around for a long time. it's really patient-driven. Once they complete their evaluation, and if they need to do any therapy, then we meet with the patient for a return visit to go over the testing, to go over what specific diagnoses they have, and then we go over treatment options. And treatment options usually, for all the diagnoses, usually range from conservative to surgical options. And it really, again, is the patient that drives what treatment that they want. There are some patients who always, try the conservative approach, and then the surgical approach would be the last option. There are some patients who just want to go straight to surgery. Majority of patients, usually about 85% of our patients, get significant improvement with pelvic floor rehabilitation. And certainly most of our surgical procedures, the success rate's around 85% as well. But certainly, there are patients, when we see them, we give them a full evaluation, including cystoscopy. We do some imaging tests of their kidneys and their ureters to make sure that we're not missing anything. And then a lot of times it can be as simple as that. Younger women sometimes just have isolated urinary tract infections with intercourse, and they can prophylax with an antibiotic with intercourse. Some patients have had a history of recurrent urinary tract infections and come in. This is very common. They're still having symptoms of a urinary tract infection, frequency, urgency, burning, but yet when we do cultures, they're negative. And a lot of those patients have pelvic floor dysfunction or spasm. And what probably has happened is that over the years, their recurrent infections have triggered some neuropathic dysfunction, and now they're in a vicious cycle, and they feel like they have an infection, but they really don't. And so that's where the pelvic floor rehab comes into play. We offer sacral nerve stimulation, which is a treatment very similar to cardiac pacemakers, and we implant InterStim. InterStim is the battery that we do, and we currently are using this for overactive bladder. Hopefully, bowel incontinence will become an indication. Many of the uses for it in Europe right now are for constipation and fecal incontinence, and we're waiting on those indications here. That will certainly be exciting because that will help quite a few patients. And even though it sounds very invasive, it's really not. It incorporates just an office test and then an outpatient procedure, and then the implant is completely under the skin. And it is exactly like the cardiac pacemaker, so patients usually are familiar with that, and once you put that in perspective, then they're more open to that. So sacral nerve stimulation is certainly an exciting technology that we've been using for more than 10 years, but it's certainly evolving. The batteries are getting smaller. They're going to probably become rechargeable. That's exciting. Da Vinci is a technology. It's basically a robotic technology that we use in the operating room. The nice thing about Da Vinci technology is that the surgeon is able to manipulate instruments within the abdominal cavity just as they would use their hands. So their wrists move the same way. And that certainly took previous abdominal procedures and turned them into laparoscopic procedures, because then they can be done the same way through the laparoscope, essentially, by the Da Vinci, as if they were done open. And the procedure that I do most with the Da Vinci is the sacrocolpopexy, which is a procedure for vault prolapse, or the prolapse of the vagina. Historically, that has been the most successful procedure for this. It has about a 90% success rate with 20-year data that's very good. It's certainly the strongest repair that we have. And it's taken an open procedure that would often be 3 days in the hospital, 6-8 weeks recovery, to an overnight stay in the hospital, and much quicker recovery, a couple weeks usually. So that's where the Da Vinci has really made a huge impact on our practice. Age range varies. We see patients in the 20s to 90s. I would probably say the average is somewhere in the 50s. Well, obstetrics and gynecology is a 4-year residency, and like its title is really two specialties in one: obstetrics, taking care of women who are pregnant and having babies, and then gynecology is obviously the surgical side. Within gynecology, there are three subspecialty areas, one of which is urogynecology and reconstructive pelvic surgery. And what made me lean towards that is that you have patients who come to you that have problems that are very important as far as lifestyle related and impact with family and things like that, that we're able to offer treatments, both non-surgical and surgical, that can usually correct the problem. And the surgeries are included in that the patients usually do well from the surgeries. They usually see a big difference, and it makes a big impact on their life. And that's probably the main reason why I chose this subspecialty. Well, we're a practice solely dedicated to urogynecology. We have fellowship trained urogynecologists. We've each had 2 or more years of subspecialty training after OBGYN. This is all we do, and studies have shown in medicine that if you do lots of one thing, then you tend to be pretty good at it. We feel that really sets us apart, is that we're subspecialty trained, we offer comprehensive services, and we're focused on women's pelvic health, restoring them back to things that they can enjoy. And that can be from playing with their kids, their grandkids, to dancing, to being intimate, things of that nature. Patients who have pelvic floor dysfunction, first of all, they've never even heard of it. They've usually been to many doctors and been told there's nothing wrong. And it certainly is gratifying to be able to help somebody, diagnose them, and to then offer them a treatment that they actually get better. And I've had some patients who've been dealing with these symptoms for 10 years, and it really is sad in a way that these patients have been dealing with this for so long. But I think it's just a matter of educating patients through this venue, and hopefully this will help patients recognize that their symptoms are because they have this problem. And it's like any other skeletal muscle. If you hear about patients all the time who have chronic neck or back or problems, and that's very common. Everybody knows about it. You get injections or acupuncture, or massage, but obviously people don't talk about these muscles because they're not out in the open. But that is gratifying that we can do that.